Hello and welcome to Pediatric Case Review. Today, we are diving into a comprehensive board review on primary ciliary dyskinesia, or PCD. This lecture will cover clinical presentations, pathophysiology, diagnostic algorithms, and management using a high-yield, case-based approach. Whether you are studying for your pediatric boards or looking to sharpen your clinical acumen, this presentation has you covered. Let's get started with our first case. Here is our first case, focusing on the neonatal period. We have a term neonate on day 2 of life who developed unexplained tachypnea and hypoxemia. The chest X-ray reveals lobar collapse. Importantly, there are no signs of meconium aspiration or sepsis, yet this infant requires supplemental oxygen for 14 days in the NICU. Based on these clues, what is the most likely underlying diagnosis for this patient? The correct answer is C, primary ciliary dyskinesia. It is critical to recognize that over 80% of term infants with PCD present with neonatal respiratory distress. Unlike transient tachypnea of the newborn, which resolves rapidly, PCD distress requires prolonged oxygen therapy, often for days to weeks. The presence of lobar atelectasis on the chest X-ray in a term baby with a prolonged oxygen requirement is a major red flag. Moving to our second case, we see a typical childhood presentation. This 4-year-old boy presents with a chronic, wet-sounding cough that has persisted since infancy. His parents also note continuous nasal congestion and thick rhinorrhea starting from the neonatal period. His growth parameters are completely normal. If primary ciliary dyskinesia is confirmed, what are the most common long-term pulmonary and sinus sequelae we should anticipate as he grows older? The correct answer is A, chronic sinusitis and bronchiectasis. The core issue in PCD is defective mucociliary clearance. Because the cilia cannot effectively sweep away mucus, secretions pool in both the upper and lower airways. This pooling creates an environment ripe for recurrent infections, leading to persistent rhinosinusitis and, ultimately, irreversible airway damage known as bronchiectasis. Notably, unlike cystic fibrosis, these children usually maintain normal growth and pancreatic function. Let's look at case number 3, focusing on a classic physical examination finding. We have a 10-year-old girl evaluated for recurrent chest infections. On auscultation, her heart sounds are loudest on the right side of the chest. You also note digital clubbing, and her CT sinus scan reveals severe opacification. This specific triad of clinical and radiological findings is pathognomonic for a well-known syndrome. What is the correct diagnosis? The correct answer is D, Kartagener syndrome. This is a specific subgroup that affects approximately 50% of all patients with primary ciliary dyskinesia. The classic triad consists of situs inversus, such as dextrocardia, chronic sinusitis, and bronchiectasis. The connection lies in embryology. Normal ciliary function at the embryonic node is absolutely essential for establishing normal left-right body asymmetry during fetal development. Let's transition to case number 4, which targets pathophysiology and genetics. PCD is primarily an autosomal recessive disorder characterized by structural and functional defects in motile cilia. When we look at these cilia under an electron microscope, we can identify specific ultrastructural defects. Mutations in genes like DNAH5 and DNAI1 are the most common culprits. Which ciliary structure is most commonly absent due to these specific genetic mutations? The correct answer is B, the outer Dynean arms. Normal motile cilia possess a classic 9+2 microtubule arrangement. The inner and outer Dynean arms are motor proteins attached to the outer doublets. They generate the mechanical force required for ciliary beating through ADP hydrolysis. The absence of these outer Dynean arms is the most frequently observed ultrastructural defect in PCD, leading directly to the immotile cilia phenotype. For case number 5, we explore biochemical markers. There is a specific gas produced naturally by the paranasal sinuses that is used as a highly effective screening biomarker for PCD. The concentration of this gas differs significantly in patients with PCD when compared to both healthy individuals and those suffering from cystic fibrosis. Which of the following biochemical findings is highly characteristic of primary ciliary dyskinesia? The correct answer is C, extremely low nasal nitric oxide. While the exact physiological mechanism is still being studied, patients with PCD exhibit profoundly reduced levels of nasal nitric oxide, usually less than 77 nanoliters per minute. This is a stark contrast to normal individuals who have levels well over 200. Even compared to cystic fibrosis patients, the levels seen in PCD are generally much lower, making it an excellent screening tool. Case number 6 addresses our diagnostic approach. A 7-year-old boy presents with daily productive cough, chronic rhinitis, and recurrent ear infections. you strongly suspect PCD, especially after a negative sweat chloride test rules out cystic fibrosis. For this cooperative child who is over 5 years of age, what is the most appropriate first-line screening test recommended by current guidelines to help guide your diagnostic workup? The correct answer is A. Nasal nitric oxide measurement. According to the American Thoracic Society guidelines, measuring nasal NO is the preferred first-line screening test for cooperative patients over 5 years old with a strong clinical history of PCD. It is favored because it is completely non-invasive, highly sensitive, and provides immediate results. If the levels are low, you then proceed to confirmatory genetic testing or electron microscopy. Following up on our diagnostic algorithm, case number 7 focuses on definitive diagnosis. Suppose you have a patient with a strong clinical phenotype and very low nasal nitric oxide levels. You need to confirm the diagnosis visually at the cellular level, so you request a biopsy of the nasal mucosa from the inferior turbinate. Which diagnostic modality is considered the gold standard for visualizing these precise structural ciliary defects? The correct answer is D. Transmission electron microscopy, or TEM. TEM allows us to clearly evaluate the ultrastructure of the cilia to identify hallmark defects, such as the missing outer Dynean arms we discussed earlier. However, be aware of its limitations. About 30% of PCD patients have normal-appearing cilia on TEM. Because of this, comprehensive genetic testing is increasingly used alongside or even instead of TEM to confirm the diagnosis. Case number 8 brings us to radiological findings. Here is a 15-year-old boy diagnosed with PCD at age 6. He is here for a routine follow-up and undergoes a high-resolution CT scan of the chest. The goal is to assess the extent of permanent airway damage, specifically bronchiectasis. In patients with primary ciliary dyskinesia, in which lung regions do we most commonly find the most severe bronchiectatic changes? The correct answer is B, the middle lobe and lower lobes. Because patients with PCD lack effective ciliary clearance, the drainage of pulmonary secretions becomes highly dependent on gravity. As a result, infected mucus tends to pool in the dependent areas of the lungs, causing maximum damage to the middle and lower lobes. This is an excellent way to radiologically differentiate PCD from cystic fibrosis, which typically damages the upper lobes first. Case number 9 focuses on creating a management plan. You are setting up a chronic care regimen for a newly diagnosed 5-year-old with PCD. Your primary objective is to preserve his lung function for as long as possible and significantly delay the onset of bronchiectasis. Among the choices provided, which intervention forms the absolute cornerstone of daily maintenance therapy for this and all other PCD patients? The correct answer is C, daily airway clearance therapy. Since the cilia cannot do the work, we must manually substitute their function. Regular chest physiotherapy and the use of oscillating positive expiratory pressure devices are the mainstays of PCD management. We often use nebulized hypertonic saline beforehand to hydrate the mucus. It is also important to note that Dornase alpha, widely used in CF, is generally not recommended for PCD patients. Case number 10 covers a pulmonary exacerbation. A 14-year-old girl with known PCD presents with increased cough, fatigue, and a 15% drop in her FEV1. You obtain a sputum culture and empirically start 4 antibiotics targeting a specific gram-negative rod known to colonize older patients. Which of the listed organisms is a classic, deeply concerning respiratory pathogen in older children and adults suffering from PCD? The correct answer is A, Pseudomonas aeruginosa. While infants and young children with PCD are typically infected with Haemophilus influenza and Staph aureus, adolescence brings a shift in microbiology. Chronic colonization with Pseudomonas aeruginosa becomes a major concern and is directly linked to an accelerated decline in lung function. When it is first isolated, we treat it aggressively with eradication protocols to prevent permanent colonization. Moving to case number 11, let's discuss ENT manifestations. A 6-year-old boy is brought in because his teacher noticed he needs instructions repeated and sits very close to the TV. Otoscopy reveals dull, retracted tympanic membranes with visible fluid. This condition, chronic otitis media with effusion, affects almost all children with PCD. What specific type of hearing loss does this chronic middle ear fluid cause? The correct answer is D, conductive hearing loss. The middle ear and eustachian tubes are lined with the same ciliated epithelium found in the lungs. When these cilia are immotile, fluid cannot drain properly, leading to chronic effusion. This mechanical blockage causes mild to moderate conductive hearing loss, which can severely impact a child's speech and language development. Hearing aids are generally preferred over ventilation tubes due to continuous drainage risks. Case number 12 deals with future counseling in a transition care clinic. You are talking with an 18-year-old male with PCD who is preparing to transition to adult medical care. An important part of this visit is discussing long-term expectations regarding his fertility. Based on the underlying pathophysiology of primary ciliary dyskinesia, which of the following statements about fertility in males with classical PCD is the most accurate? The correct answer is B. Infertility is common due to a motile spermatozoa. The flagellum of a sperm cell has a structural arrangement nearly identical to that of respiratory cilia. The same genetic defects causing lung disease lead to asthenozoospermia, meaning the sperm cannot swim. It is important to counsel patients that actual sperm production is normal, meaning that assisted reproductive technologies, like IVF, are highly successful for these men. Before we wrap up, I want to invite you to take your studying to the next level by joining our exclusive Pediatric Case review community on Patreon. By subscribing, you get access to all our videos neatly arranged by body system, high-quality photo decks of these presentations, and direct community support. It's the perfect way to practice at your own pace. Comment below this post for details on how to subscribe. Case number 13 highlights congenital associations. We have a neonate diagnosed with PCD who is undergoing an echocardiogram to screen for structural anomalies. We know that roughly 12% of PCD patients have congenital heart defects strongly linked to underlying laterality issues. Which of the following specific conditions is most strongly associated with the severe laterality defects and cardiac anomalies we look for in these patients? The correct answer is C. Heterotaxy syndrome. While many PCD patients have situs inversus totalis with a structurally normal heart, a critical subset has situs ambiguus or heterotaxy. This random arrangement of internal organs carries a very high risk for complex congenital heart defects, such as transposition of the great arteries, as well as splenic abnormalities. This is why every newly diagnosed PCD patient with a laterality defect must have a screening echocardiogram. Our final clinical scenario, case number 14, is a crucial differential diagnosis question. Both cystic fibrosis and primary ciliary dyskinesia present with chronic suppurative lung disease, nasal polyps, and eventual bronchiectasis. However, a sharp clinical history can usually distinguish between the two right in the clinic. Which of the following clinical features is highly characteristic of cystic fibrosis, but is generally completely absent in a patient with primary ciliary dyskinesia? The correct answer is A. Pancreatic insufficiency. Around 85% of cystic fibrosis patients suffer from exocrine pancreatic insufficiency, which leads to malabsorption, steatorrhea, and severe failure to thrive. In stark contrast, primary ciliary dyskinesia does not affect the pancreas at all. Children with PCD typically maintain perfectly normal growth curves and nutritional status, making this a vital differentiating factor when you are evaluating a child with chronic wet cough. Thank you so much for watching this comprehensive presentation. I hope this deep dive into primary ciliary dyskinesia has provided you with high-yield pearls for both your clinical practice and your upcoming board exams. Please make sure to follow and subscribe to the Pediatric Case Review channel for more informative, case-based presentations. If you have any questions or need further clarification, drop a comment below. See you in the next video.